So I'll have to defer to Vanessa. I think I have 5 minutes to cover epilepsy, but we should 20 minutes for epilepsy. So good. It's an easy topic. We should be able to get through it. And so I'll just keep talking until Vanessa tells me to stop, but I'll try to get through as much as I can. The main reason people come to see us is epilepsy. It's it's one of the kind of the scariest things in the syndrome, and it's what I specialize in. I have some slides that I'm just going to skip because you've seen these, you've seen that, that's our clinic we talked about a little bit. So I always like to start with seizure types and epilepsy syndromes. It's very confusing, the terminology. We've had people come to us on seizure medicine, seizing, that have said, oh, we don't have epilepsy, it's a seizure disorder, but it is epilepsy. The definition has always been 2 or more unprovoked seizures is considered epilepsy, and unprovoked means that you didn't have a seizure because your blood sugar dropped super low or you got hit in the head with something. They were just seizures. Recently, they changed the definition to 1 seizure plus what we call epileptiform abnormalities on EEG, so spiked, sharp waves, kind of things on the EEG that kind of tell us that the risk of seizure is high. So if you've had 1 seizure with an abnormal EEG or 2 seizures that weren't caused by something obviously not due to the brain, it's technically epilepsy. Some people with epilepsy have 2 seizures ever, some have thousands, so either way, it's still epilepsy. So then there's seizure types and epilepsy syndromes. The seizure types are the actual, describe the seizure itself. So if you have a seizure, it's going to be a certain type. It's going to be one of those we're going to talk about. Epilepsy syndrome, so you'll hear terms like Lennox-Gastaut, those kind of things. They are, what an epilepsy syndrome is it's, you have 3 criteria. You have the seizure type, you have certain EEG findings, and then you have cognitive outcomes, so whether kids are typically developing or not typically developing, and then you put those together, you get an epilepsy syndrome. Hopefully I'm not going too fast, but I'm just trying to get through. So 2 different seizure types, you can either have a focal seizure or a generalized seizure, and I think the pictures are probably better. So if you look, even if you've never seen an EEG before, you can kind of see that part of it's not quite the same as the other. So just real quick, if you're looking at an EEG, it's always left, right, and it kind of goes front to back over the ear, then down the middle. So this is someone who's having a seizure in the kind of in the top of the head on the right side. But so as you can see with focal seizures, most of the brain is actually doing pretty well. Everything looks normal except for that one little neighborhood. With a generalized seizure, the whole brain's affected at once. You can see kind of every channel is affected. So that's kind of the difference between, you'll hear focal. The old term was partial. A lot of people still call them partial seizures. Focal seizures are generalized seizures. And the way I like to think about seizure types is if you have someone who's typically developing, doesn't have a genetic syndrome, developmental delays, autism, they'll have either focal seizures or tonic-clonic, myoclonic, or absence. If you have atonic, atypical absence, tonic, spasms, those are the seizure types that we really only see in kids that have developmental issues. Just real quick, just to kind of go through the different seizure types. So generalized tonic-clonic is what everyone thinks of when you think of a seizure. Kind of eyes rolled back, drooling, everything shaking, kind of the whole body shaking at once. The tonic means stiff, so if you not that anybody wants to watch one of these, but if you look closely at first, there's a stiffening and then there's the shaking. So the stiffening is the tonic, the shaking is the clonic. That's tonic-clonic. Myoclonic, we heard a little bit from Stephanie's talk a while ago. So myoclonic is, like I said, if you're falling asleep, you twitch, that's a myoclonic twitch. If you have big ones of those when you're wide awake for no other good reason, that's kind of suspicious for a myoclonic seizure. And then atypical, the difference between typical and atypical absence, if it comes up, typical absence are seen in typically developing kids. The EEG shows 3 abnormal bumps per second. That's kind of what that was. That's a typical absence seizure. The atypical absence are what we see in kids that have developmental issues. And the couple differences, one is that they're longer. Typical absence, they last a few seconds. You just pop right out of it and you kind of pick up where you left off talking. Atypical absence can last 30 seconds, a minute, 2 minutes. They're typically longer. One of the big things that you'll notice is with atypical absence, you're not always totally out. Like with a typical absence seizure, you're just out, and you just, people aren't aware of anything. They pop back in, and then they just kind of pick up. With atypical absence, they're not always fully out. That's the big difference with those two. And then the ones that we see with kids with development, so kind of the main seizures in DUP15Q, they can have any of these, but atonic, absence, tonic. So atonic is loss of tone, and I actually have a good picture for that. So this is an atonic seizure, and the reason I like this is it kind of describes what's going on, even though it doesn't seem like it. It does. This dark stuff here is muscle artifact. So like if you kind of put your fingers up here and you bite, then you can feel that muscle tense. So when those muscles are tensing and the EEG is on top of it, you get that thick black stuff. It looks scary, but it's just muscle. So when you have an atonic seizure, you kind of lose your tone, so all your muscles go kind of relaxed. So I'm having trouble with this. So right here you see, just kind of the background EEG and all this muscle artifact, and all of a sudden, you can see kind of the atonic seizure itself doesn't look that impressive. It's kind of this little slow wave and maybe a little bit of a lower amplitude, but what you see is the muscle artifact just stops for 2 seconds and then picks back up. So that's what you see. It can either be a full body drop or a head drop, and it's hard unless you've seen a bunch of them, but some kids will just be tired and they're just kind of like nodding off. And so sometimes it's hard to tell, but an atonic seizure is really quick, and it's really, you lose tone and it's just a quick drop. And then after the drop, there's a second or two of confusion, and then they kind of perk back up. Whereas if they're tired, it's kind of more of a slow, and then they kind of wake up and look around. So sometimes it's hard to tell, but that's kind of the main thing is you just immediately just lose tone like that. The head just drops, or sometimes the whole body drops. And then after a second or two, they kind of perk up. But that's why I like this example, because you can just see where the muscle just stops. With tonic seizures, so this is an example of one. Again, you don't need to memorize the EEG, but what happens is you have this kind of abnormal background, and then it just kind of flattens, and it's not like an EKG flattening, like it's not scary like that. It's just that you have this kind of chaotic background, and then I'll show with the spasms later, but like when an EEG's really kind of like high amplitude and busy and just like very abnormal, it's hard to make kind of seizures like the seizure we saw before with that focal seizure. You just can't do that because the EEG is so abnormal, you can't make those rhythms. So the one thing it can kind of do is just kind of flatten out. So that's what you see with tonic seizures and spasms. And that's why they're the toughest to treat, because the EEG is generally the most abnormal around it, and then you get these difficult to treat tonic seizures and spasms. I'll get to spasms after, I think. So epilepsy specifically and DUP15. The seizure prevalence, we did a seizure survey a while back. I think it's probably pretty accurate. It's about 50 to 60%. As you saw in the slides, I think that Stephanie had, it's much higher in our kids, but that's kind of who comes to see us more than not. But about 50 to 60 is probably pretty accurate. And then, but I don't go into the details. So with epilepsy and DUP15, there's seizures that, like some of the Angelman syndrome, for example, it's a generalized epilepsy. Everything's kind of whole brain. When it is, it's usually like something in the neurons itself or something in the network. You get this whole kind of whole brain going at once. And I think the picture is probably better. So this is an MRI of one of our kids, and it's, again, you don't have to actually know MRI findings, but like this is the hippocampus. You probably heard that. That's kind of, where memory is stored. You see it here, it looks different from the other side. This is what we want it to look like, kind of big and juicy, and you can see all the little lines in the middle. It doesn't show up quite as well, but this one is clearly smaller. You can't see the details, and if you look at it on the MRI machine, it's a little bit brighter. So it's just kind of an example that in DUP15, when they've looked at brain segments under a microscope, there's lots of little areas that we call dysplasias or heterotopias, so little pieces of brain that just aren't in the right place, they aren't kind of formed right, and there's lots of little ones. There's lots of different places where seizures can come from. So if you think about I don't know, probably because it's almost lunchtime. If you think about like a pepperoni pizza, and there's like one piece of pepperoni on every pizza, you think about each one of those as being like a seizure generator. And if it's just coming from one piece of pepperoni, you're going to get those focal seizures. It's going to be one part of the brain. It's not as hard to treat. You don't see as much developmental regression. When most of the pepperonis, or even all of them, are kind of doing their own thing in each part of the brain, then they kind of cluster together, and all the networks kind of match up, and they become generalized. So you're starting with focal. So pretty much most kids, they're basically, the way their seizures start is focal. But in more severe cases of epilepsy, they kind of come together and give you these more difficult to treat generalized seizure types that I'll get into. I hope that makes some sense. But these are the type that just from our survey in the way back, but it just kind of shows, you have the tonic-clonic, the myoclonic, the ones that we see in everybody, and then atonic, tonic, and then spasms. And that's one of the by far the most common cause of spasms are these areas of dysplasia. So whether it's Dup15q or something tuberous sclerosis, where you have these tubers that are dysplastic. So just parts of brain that aren't either formed right or not in the right spot are the most frequent causes of spasms by far. And so the fact that when you look under a microscope, you see these little tiny areas that just aren't kind of built right. They're not big enough usually to see on MRI, so that's why we don't see them on MRI, but they're there. And that's why there's such a high rate of spasms, because it's this kind of little, what we call dysplasia, just like kind of not formed right parts of brain. So that's isodecentric. That's what basically I was talking about. For our kids with interstitial, it's a little bit different. In our seizure survey, there were 2 out of 12 had seizures. We should probably update this, but the first 11 kids with interstitial, we saw 2 had seizures. And then in a study that Larry Reiter and his group in Memphis did, looking at interstitial duplications, 1 out of 13. Talking to Shafali in Charlotte yesterday, it's 1 out of 16, I think. So pretty much all the reports are pretty consistent. There is a risk, but it's not nearly as high as the kids with isodecentric. And there was actually a really good paper that came out a few years ago that was looking at seizures in autism, and the prevalence, I'd say, is 25%, but it's not the same for everyone. The kids that had really severe motor impairments and more significant intellectual disability, they had more of a 50% risk, and those that were really more mildly affected, they were more verbal and had very little motor delays. They were more like 7 to 10%. So if you look at the Dup15 in general, it's probably less than 50%, but you have to really kind of differentiate between interstitial and isodecentric, because it makes a difference. And that's why we're looking at the interstitial triplications, because the question is what is the risk there? Is it more like isodecentric, or is it more like interstitial? So just kind of by age, spasms, I don't know if I already skipped over the slide, but in our study, about 26% had spasms, so 40% of those with seizures, so that became about 25% in general. And again, seizure surveys can overestimate, so maybe it's more like 20 to 25%, but talking to Shafali and Charlotte at UCLA, their numbers are pretty similar, so I think that's probably accurate. So there's a really high rate of spasms. Again, there's certain disorders, the ones where like Dup15, tuberous sclerosis, where you have dysplastic parts of brain, so parts of brain that just aren't quite formed right, where the spasm rate is high. They typically begin less than a year. If they're infantile spasms, they're always less than a year. That's the kind of the definition. The difference between infantile spasms, it's just if you're an infant and you're having them, it's an infantile spasm. The seizure type itself is a spasm, and if you're an infant, they call them infantile spasms. But in these syndromes where you have the abnormal parts of brain here and there, you can get them at any age. And so what's kind of unique about Dup15 that we've seen is that for Lennox-Gastaut syndrome, which I have later on, so these really tough to treat seizure types with drops and tonic seizures, they kind of, when you read the literature, the most common age for them to start is about 27 months, so 2-3 years is kind of the typical. In kids with Dup15, it's more like 7 to 9, which is, it's tougher because, if you have spasms or not spasms, we can tell most people, well, if you get to 6 or 7, you're probably good. But for kids with Dup15, it's really if you get to 12, you're probably not going. So it's a longer wait. It's not cool, but it's just the way the syndrome works. And I don't know why it's later. It's just that's what we see. but that's when we tend to see the more difficult seizures start. And we were talking about yesterday, age of onset is important for, am I running over? You're staring at me? Okay. All right. So I'll skip this. So the two syndromes, I'll go quick. So Lennox-Gastaut, this is a confusing part. When you get just say, they say, well, we have Dup15 syndrome. Why do we have Lennox-Gastaut syndrome? The genetic syndromes are kind of the root cause of everything. You have this genetic syndrome, it's causing all the issues. The seizure syndromes are just describing the epilepsy. That's all it is. It's like the type of epilepsy fits these criteria, so it's called Lennox-Gastaut syndrome. And they probably shouldn't call them syndromes. They should have another name so it's less confusing. But you can have Lennox-Gastaut for hundreds of reasons. But that's what we commonly see in Dup15. And there's we saw that the EEG earlier was 3 spikes per minute. 3 spikes per second. In Lennox-Gastaut, it's less. You can see these blips. These big lines are 1 second, and you get there's less than 3 per second. So it's that we call slow spiking wave. That's one of the criteria. West syndrome, it's semantics. If you have spasms, infantile spasms, an EEG finding called hypsarrhythmia, and delays, that's called West syndrome. It's again the 3 criteria. So this is what hypsarrhythmia looks like, if the term's ever used. I had to kind of turn the volume down because when you look at it, it's just you can't see anything. It's just a mess of black lines. The waves are just really tall. They're chaotic. They're not organized. And that's when you have spasms, it's not so much that, they're quick little seizures. We don't really think those are an issue. The issue is this. It's the EEG, and that's what's going to cause the developmental delays and everything that comes with it. This is what so again, kind of like the tonic seizures, the EEG is so abnormal. What happens is you have this, again, I turned it down just so you could see it, but you have this crazy tall EEG, and then really all it can do is just kind of flatten. So it flattens for about a second when the spasm hits. And the way to differentiate a spasm from an atonic seizure is with an atonic seizure, you just lose your tone, you just drop. With a spasm, your head is kind of forced down, and that's hard to differentiate. But when your head goes down, often your shoulders will come up. So if you're having head drops and shoulders are coming up, it's not atonic. If it's atonic, everything just kind of gets limp. If it's a spasm, the head's kind of forced down, the shoulders will come up, and then that's when you say, okay, this probably isn't atonic, it's probably a spasm. And the treatment's different, so that's important to know. And this is, I always like to put a positive slide after those negative ones. This was a kid we treated for spasms, and this is the EEG after. You can really, with the right treatments, make a dramatic change. So the good news is there's good treatments that can change. You're going to cut off half the seizure talk? And then in older kids, it's interesting. So hypsarrhythmia is really in infants, and after a year, it's really unusual. So this is one of our 9-year-olds with Dup15, and they have a fairly normal EEG. So the spasm kind of looks the same. It's a little flattening, but it's not coming from a crazy background. And this is one of the reasons I really like this slide is, we're talking about how you have these little spots that cause seizures, and then they can run together. If you actually look at the spasm, so it's left, right. So if you look at the right, there's this kind of little burst of spikes, this little abnormal thing, and it starts on the right before the left, so it starts here, and then so these spasms are probably kind of starting on the right. So they kind of start here, then you see them kind of catch up on the left, and then at that point, it's everywhere, and then you get the spasm. So you get that little short lead-in from the right side, it spreads quickly, and then you get the spasm. So just an example of how it's from different places kind of running together. I'll skip this, I guess. All right, so status, it's not, it's a thing, but I think there's more important stuff to catch. But status is a really long seizure or lots of little seizures without coming back to baseline. Non-convulsive status, there's more stuff I want to talk about. So the EEG and Dup15, I think this is important. I won't go into details, I'll just show you pictures. So one of the things that when we first started seeing kids, we saw what we call beta activity. So it's this really fast activity. I know it's hard to see, but lots per second. And so when we initially saw this, we presented at conference, and then Shafali and her group were the first ones to really look at it very formally and to quantitate it. We don't think it's more of a marker. It's kind of telling us, like, this is DUP15. We see this in kids that have, they're on benzos, they're on Valium, they're on whatever. So it can kind of maybe point to which genes are maybe affected. It can kind of be a marker of the syndrome, but it's not really a problem. So if you see, oh, it's normal except for the beta activity, it's really nothing to worry about. This is more concerning. So this is what we see in sleep. So kids that have the Lennox-Gastaut type syndrome, this is something that I had actually not really seen before we started seeing kids with DUP15. It's very unique to the syndrome, and it's when you sleep, you have kind of these normal sleep waves and these really tall, fast spikes. And what's interesting is with some of these spikes, or for most of them, we don't see anything. We just see like lots of these bursts in sleep, and we know it's not good for the brain, and we know that it's going to lead to like Charlie was saying, it's going to lead to developmental issues because you just don't want to have this going on when you're asleep. But every now and then we see like a little subtle movement, and with some kids, they actually will have what kind of seems like a tonic seizure. So with tonic seizures, you typically have that flattening, and you're typically awake. But with some of these bursts, we've actually seen kids kind of stiffen, so it's not exactly a seizure, but it's not exactly not a seizure. It's really, I know it's complicated, I don't quite get it, but sometimes we see movement, sometimes we don't. But what we know is that if you're doing this all night, you're not only, like Shefali was saying, you're not only like not making you're not like learning, you're not keeping what you learned, you're not making memories, but you're also not getting quality sleep. Because if you think there's certain waves you see in sleep, there's like these we call spindles and whatnot. When you have all this, you just don't get that normal progression of phase 1, stage 2 REM. So it's bad on many levels, but that's kind of what we see. Let's skip that one. And then if it's kind of all night, we call it continuous spike wave of sleep. So even if there's not clinical seizures, if we see this on EEG, it's really important to treat it because it's really going to affect development. And that's kind of the key with that one. So actually, I don't have too much more. I'm just going to go really quick with medicines. But this is a really important slide. You treat the comorbidities. I kind of said it earlier. If you're not sleeping, if you're not pooping, it's just the seizures become really hard to treat. So even though you want to prioritize seizure treatment, you say, I'll worry about the constipation later. The better you can make the rest of the body, the easier it is to treat the seizures. So we always ask, are you sleeping? Are you pooping? Is there anxiety? And whatever we can treat to make that better is going to make it so much easier to treat the seizures. So definitely, if seizures are the big thing, don't ignore the rest of it because it's going to make the seizures better. I know it's hard to prioritize, but the more you can improve sleep, anxiety, constipation, reflex, the easier it is to treat the seizures. Treatment options are medicine, diet therapy, surgical options. Medicine is the mainstay. For diet therapy is very effective. It's just hard to do in some kids, but for the kids that have been able to do it, it's super effective. Any given medicine has about a 40% chance. Dietary therapy, it's more like 2/3, so it's a higher percentage of kids, but again, it's not always the easiest thing. And so I'll kind of go fast to kind of wrap up. But when you're looking at medicines, these are what we call broad spectrum medications, kind of the early ones. I won't go through all of them, but these are all medicines that will treat, in theory, maybe not as much ethosuximide, but they can all treat drops and tonic seizures, and some treat myoclonic seizures better than others, but we call them broad spectrum because they can treat many seizure types. These medicines, phenobarbital, dilantin, which can be used for status, but Tegretol, Trileptal, Neurontin, Lyrica, those are medications that if you clearly have focal seizures and it hasn't gotten to that Lennox-Gastaut stage, these medicines will work. If you're on one of these and then things kind of get worse, they change, you're seeing head drops, tonic seizures, they're probably not going to worsen things. It's possible, but they're probably not going to help. So at that point, it's time to move on to like a broad spectrum. And what's been nice is so this is from the beginning of time until 2011. And then since 2011, we've had a bunch of new medicines. A couple of them actually having FDA indications. So just because the FDA doesn't indicate a medicine for something doesn't mean we don't use it. A lot of times it just depends on what's easiest for the companies. But it's nice that we have a couple medicines that are indicated for Lennox-Gastaut. But a lot of these newer ones, clobazam, Banzel, Vimpat isn't technically a broad spectrum, but we use it and it does help. This one was taken off the market because it turned kids' skin blue. Ficampa. The other nice thing with some of these medicines is that they were the first of their kind. So lacosamide, Vimpat, it blocks sodium channels, but a little bit differently than the other ones. Potiga was the first potassium channel blocker ever. And we don't know if it helped because it made kids' skin blue and they stopped using it, but they may try to fix that. But it's off the market. Fycompa is the first one. The medicines either kind of work on the brain cells, like with chemicals coming in and out, or they increase the amount of GABA, which is the chemical that quiets things in the brain. This is the first medicine that acts on the system that excites things, so it kind of quiets the excitement versus increases the quieting. I won't talk about cannabinoids because that's coming up. Brivaracetam, if people don't know about it, it's like Keppra but without the crankiness. So if you've been on Keppra, you got too cranky, you had to come off, this is really worth a try. It doesn't act on one single receptor that Keppra does, and that seems to be the one that causes the crankiness. So there's a lot of new medicines that are really good, and so this has been a really good thing in the last 10 years. And I just put this slide up. Don't look at the details, but it's I don't look at the details, but it's kind of like what helped, what didn't help, and the take-home message is that there's nothing that stands out. What we see with Do15, it's really hard. We've had we see kids that have 30, 50, 100 seizures a day, and some respond beautifully to Fycompa, but not others, and some it's Banzel and not others. It's not like there's one or two medicines that we've seen like, oh, these ones work really well. They can all help, and they've all helped one person at some point, but there's no clear medicines that work better than the others like there are in some syndromes. The one thing that we do see that's better, vigabatrin and ACTH or prednisone, like the steroids, those are the two main medicines to treat spasms. So if you have spasms, the broad spectrum medicines will help, but if they're truly spasms, you kind of need one of these. And what we found, just to kind of explain, steroids worked way better than vigabatrin. Doesn't mean that vigabatrin won't work, but in the kids we've seen, it was really impressively skewed. Tuberous sclerosis is the opposite. They do much better on vigabatrin. In epilepsy in general, they both work equally as well. But in Do15, we've seen the steroids work way better. And we use steroids for Lennox-Gastaut when kids just start ramping up, seizing, nothing's cutting it. We'll just put them on prednisone, like big doses of prednisone. And more times than not, it can really help. And it's not a long-term solution, but if it quiets things, if you're having 40 seizures a day, you go on the prednisone, you're down to 2, like that just buys us time to play with the other medicines and kind of quiet the seizure cycle. So it can be really effective. And sometimes you get lucky and you break the cycle and it just kind of stays better for a while. Cannabinoids is coming up. I'm not going to talk about it. I could talk about this for a while, but ketogenic diet is really effective. About 2/3 of people have a really good response, 50% or more seizure reduction. The issue is it's hard to not give the kids cupcakes. Kids that have G-tubes, it's the kind of the ideal scenario. It's just changing the formula. Or if you start kids like at age 1.5, age 2, like young kids that haven't experienced the joys of cookies and whatnot, they don't know any better, and so they'll actually reach for the avocado instead of the cupcake because that's what they know. So, but it's hard to do, but it's really effective. And so we use a lot of dietary therapy. This is a milder diet. In the interest of time, it's an easier diet. It's maybe not quite as powerful, but it's pretty close. And just one more point about diet. It's going back to the whole GI brain thing. For the diet therapy is really effective, but for kids that aren't getting calories, they're what we call failure to thrive, they're losing weight, they're getting super skinny, that's a big stress on the brain. You're not getting calories, those calories aren't going to the brain, and it'll worsen seizures. Sometimes we've had kids we put in a G-tube because they're not eating. It's like, all right, let's try the G-tube, we'll do keto, and then we don't do keto because just getting calories stops the seizures. So it's if you're having a lot of, someone's having a lot of seizures and they're just not eating, they're getting skinnier, probably better than any seizure medicine is just getting them calories. And so that's where a G-tube can be, and they're temporary, they can be temporary. So the key is just getting the calories in, and if you have to do it with a G-tube, it can really be life-changing. And that's the group of us, and that's the clinic itself. It's no, just kidding. That's Mass General, but that's so. The 10 minutes was good. I got through it.